So we're here today to talk about what's happening in our communities as a third sector. How can we help tackle vaccine hesitancy and confidence for our communities to get vaccinated? So we'll be quite positive, I hope. We don't want to explore any of the more outlandish social media conspiracy theories, etc. We're here to have a constructive session, and I hope that that's the spirit that we'll all participate in. But without further ado, I will pass over, I think, first of all, to Professor Eleanor Riley, who is going to talk science to us. That's very exciting. Eleanor.
Hi, thanks, and hello everybody. I'm just about to start sharing a screen, so hopefully that will work. There we go. Okay, hopefully you can see that. So my name's Eleanor Riley, and I am Professor of Immunology and Infectious Diseases at the University of Edinburgh. And although I haven't directly worked on COVID, I have a lot of experience with vaccine development, running clinical trials, and have been doing a lot of work on explaining COVID-19 and COVID-19 vaccinations to the public, both through these kinds of activities, but also through press and broadcast media. So hopefully you'll find this interesting. So I've only got 6 slides, and this first one is just sort of to explain to you how the vaccine works. So hopefully you can see my cursor. So on the left-hand side, this is just a kind of diagram of the COVID-19 virus. And in the middle here, you've got the genetic code, the RNA that encodes for everything that the virus does. And here in blue on the outside, you've got the spike protein that I'm sure you've all heard of. And it's the spike protein that allows the virus to stick onto particular targets on the human cell, which allows it to infect. So this is the part of the virus that we really want to protect against. And one way to do that is to induce antibodies, these little red things here, that bind onto the spike protein and mean that it can no longer stick onto the host cell because the spike protein is now blocked. The antibodies get in the way and stop it binding, and therefore the virus can't infect our cells and can't cause any damage. So with that in mind, there are at least two types of vaccine. The ones used in the UK at the moment, the Pfizer one, takes the little bit of this RNA molecule that actually codes for the spike protein, puts it inside fat droplets called liposomes, and then simply injects those into your arm. That RNA that is inside the little fat droplets goes into the muscle cells in your arm and then tells the muscle cell to start making bits of spike protein. Those bits of spike protein then induce the production of antibodies and cells which will kill the virus or the virus-infected cell. The Oxford AstraZeneca vaccine is a little different. It takes this RNA and inserts it, actually as a DNA molecule, into a carrier virus called an adenovirus. And then that adenovirus, which has been disabled so it can't cause an infection itself, that essentially dead adenovirus carrying that little bit of genetic code is injected into the muscle cells and again causes the cells to make the spike protein so that we make an antibody response. So how does the vaccine work? So when you are exposed to somebody who's infected with COVID, for example, they cough, you inhale those droplets and they go into your nose and into what we call the nasopharynx, the back of your throat. And they infect the cells in this area, and that's why the test that we do sticks a swab up your nose or down your throat, because that's where the initial virus infection takes hold. And that causes your coughing and sneezing and feeling a little bit unwell, but in itself is not particularly dangerous. The virus is dangerous when it gets down into your lungs and causes pneumonia. So the idea is that the vaccination and the antibodies and the cells induced by the vaccination stop the virus at this point. It gets in, it's attacked, and it can't go any further. And therefore it doesn't get to your lungs and doesn't cause the severe disease and death that we're so worried about. And what we know, both from the clinical trials and from the monitoring that's been going on after the vaccine's been rolled out, is that vaccination reduces infection, so this bit of the process, by about 70%. And if you are one of the unfortunate people who does get infected after you've been vaccinated, it also reduces the likelihood that you'll spread it to anybody else in your household by about 50%. So overall, that means that vaccination reduces your likelihood of being infected and infecting somebody else by over 90%. And we also know that if the virus does get in and gets past this initial defense, if it gets to the lung, it is very effectively dealt with by the immune response induced in the lung and reduces severe disease and death. I've got 90%, 95% here. The data from yesterday say it's over 97%. And that, remember, is 97% reduction in your previous risk of getting a severe disease. And depending on how old you are, that risk obviously varies as well. So vaccine safety, a lot of people are worried about this because we've developed these vaccines so much more quickly than usual. So how is it assessed? So there's a long stage that goes through first in laboratory animals where they're infected and vaccinated and infected, and we do blood tests, we look for symptoms, we do post-mortem analysis to make sure that the vaccine works, to make sure it's safe, and to make sure it can prevent infection. If it gets through that stage, then it goes into a small number of healthy adults, usually young adults, who go through the same blood tests, clinical monitoring, and detailed blood tests to look for any potential side effects. And then only after that has proven that the vaccine induces a good immune response and is as safe as we can be sure it is, then it goes into larger numbers of adults in the clinical trials, and you will have heard about those. They started in May last year, and the initial results were reported in October. And then, as I'm sure you're also aware, we also do long-term follow-up of everyone in the clinical trial, and we do routine monitoring of the vaccine rollout. And this is where the MHRA yellow card scheme comes in to report suspected side effects. And this is really important because it detects those rare effects, the 1 in a million, 1 in 100,000, such as the blood clots that I'm sure you've heard about, which we can't pick up in these studies because these studies involve just a few thousand people. So there will inevitably be 1 or 2 side effects that crop up once the vaccine has been rolled out. Oops, sorry. Oops, I did something wrong there. There we go. So one of the things that people are asking, it's very timely at the moment, of course, is what happens once you've been vaccinated? Can you behave differently? So more than, in fact, it's now more than 90% of those at risk of severe disease have had at least 1 dose of vaccine. And we are seeing a very, very sharp decline in hospital admissions and deaths. And once the rest of the adult population, so that's people over the age of 18, have been vaccinated, then the number of cases that we see on the daily, which is currently about 2,000, will also start to go down. And we are fully expecting, as we've seen so far, that this continues even as we emerge from lockdown, because a very large proportion of the population are immune and not able to be infected or transmitted. And we're therefore expecting life to return to something close to normal. But there are some caveats to that. The vaccines reduce but don't totally prevent infection, as I've said, and therefore there will be some vaccines circulating, particularly whilst young adults and children haven't been vaccinated. And therefore anybody who hasn't been vaccinated or who is immunocompromised and therefore unable to respond to vaccine will still be at risk. So there is a potential, another little wave of hospital admissions and long COVID cases as we open up, but we now think that's going to be a very small wave because of the very large proportion of vulnerable people who've been vaccinated. So I think I'm not going to dwell on this slide because I think it's been covered in recent announcements for the government. I think things are going to go back to normal, and we just need to keep an eye on what's happening internationally in terms of new viruses, new variants, and making sure that people who haven't been vaccinated are still protected from infection. And the very last thing I want to do is to share some lessons that I've learned about talking to people about vaccine hesitancy. So people are right to have concerns, and it is perfectly okay for people to want to ask questions and to have them taken seriously. And I, as a scientist, have really appreciated the need to have an open and honest conversation with people about what we know and what we don't know. It's very clear that people place most trust in people close to them, so friends and family, and trusted community leaders, so their GP, carers, and community and faith leaders. And these are the people like yourselves who need to feel empowered and informed to answer these questions. And that really is the purpose of our discussion today. Misinformation, as we're all aware, can be very damaging. It will cause vaccine hesitancy, but it can only be overcome by taking those concerns very seriously and countering these spurious claims with hard evidence. And finally, it's important to remember that people are not very good at assessing risk, and we need to get better at helping people to assess the risk. And the one that sticks in my mind that a fellow immunologist told me is the biggest risk you will have in getting a COVID vaccine is whatever means you use to get to the vaccination centre, be it walking, taking public transport, or driving. The risks of coming across a serious or in being involved in a serious accident on your way to the vaccine centre is the most risky part of the process. So I'm going to stop there and stop sharing my screen and allow Carey to take over.
Thank you, Eleanor. I'm just going to bring mine up, hopefully. I had it 2 seconds ago. Where has it gone? Okay, here we go. Apologies. Is that sharing okay? Excellent, good. So thank you, Eleanor. That was really useful for me to listen to as well, and it's great to see you all tonight because you have such a key role to play, as Eleanor was saying, in helping to support our communities to feel confident in getting vaccinated. So it's really important that we understand what the specific concerns are. So I was just going to speak just very briefly about vaccine rollout in the kind of practical sense, because obviously as GPs we've been fairly involved in that. So vaccine rollout has largely had 3 phases. Phase 1 for the top 4 risk groups, residents in care homes, older adults and their carers in care homes, everyone over the age of 70, frontline health and social care workers, and those in the clinically extremely vulnerable group, which in Scotland is called the shielding group. It's the same thing. And then phase 2 are people over the age of 50 and people with underlying health conditions, which are just listed down the side there, which make them more at risk of serious illness from COVID if they were to catch the infection. And then phase 3 is all remaining adults, so those over the age of 18. So we're doing reasonably well with getting through those numbers. It's been a fairly unprecedented vaccine campaign, it's fair to say, in terms of the history of the NHS. So in terms of where people are getting their vaccines done, it does vary a little bit across Scotland, and each health board has got a slightly different strategy. But in Lothian, everyone over the age of 75 years who is able to come to the surgery has been vaccinated in their GP practice. And also everyone in the shielding group has been invited to come in to be vaccinated in their GP practice too. So they were the people that we were focusing on as GPs, and everyone else was invited along to the mass vaccination centres or the local hub vaccine centres, and there are 5 of those in Lothian, or in Edinburgh rather, in addition to the mass vaccine centres, which are the really big ones like the Queen Margaret and the EICC. So there have been a few challenges to vaccine rollout. As you can imagine, it's been a new vaccine, there's been lots of learning around it, And some of it is just the logistics of how we deliver the vaccine. The Pfizer, for example, needs to be stored, as you'll know, at very low temperatures, which means that we can't really easily do it in a GP practice because we don't have those fridges. Once you open a vial, you have to use the vial within 6 hours, which is also quite logistically challenging because it's not like a flu vaccine where we can just go and grab one from the fridge and give it opportunistically when someone comes in for something else. Once you've opened the vial, you have to complete the vial. And you usually get 11 doses in a vial. So it takes a bit of forward planning to make sure that we make the most of vaccines and don't waste them. And then, of course, every vaccine needs 2 doses. One dose will give you reasonably good protection, but the second dose will give you much better protection. So there's some logistics around that to make sure that everyone is invited in for their second dose before the 12-week period is up. Travel to mass vaccine centres, I think, has been a challenge for quite a lot of our patients in Edinburgh. There are, of course, the big mass vaccine centres where we're talking about, and the hubs, which were deliberately located in the more socially economically deprived parts of the city, with an intention to try and support people who struggle to get access to transport to be able to easily get to a vaccine centre. But it's not always worked as well as we would ideally have liked it to work. So we have found that, for example, lots of people from East Lothian are travelling up to the Craigmillar hub, and people from our catchment area are travelling over to the Ingliston Mass Vaccine Centre, and it's not always worked well. So that has been difficult for some folk. Receiving vaccine invites, if you're getting invited to one of the mass vaccine centres or the hubs, you get something in through the post. So people don't always get them in time, but they usually do, but it's not always worked as well as ideally would, but it has got better as the rollout has gone on. And rescheduling appointments is something else that is done through a national line, and I'll share some just useful resources at the end. And often people find that they need to reschedule their appointment either because they can't get to the centre for that date, it's maybe arrived too late, or they don't have transport to get there, or they're not well and they need to reschedule it for another time. So sometimes that can feel a wee bit tricky for folk, or if they're needing to reschedule it to somewhere nearer to home, that has meant for some folk that they can be rescheduled, but it's delayed their vaccine. I think one of the most challenging things, certainly from our point of view as healthcare professionals, is just the constantly changing evidence and guidance, which is completely expected with any new vaccine. But we have to kind of keep our eye on the ball and make sure that when things change or new guidance comes out, that we're as up to date as we can be about which vaccine is most appropriate for which person, what the intervals are between doses, what the potential side effects are, for example. So it's not easy for anyone, and I do understand that. And the vaccine hesitancy or low confidence, I think, is something that we really need to understand and do our very best in trying to help people have confidence in being vaccinated. And we know that vaccine confidence or hesitancy is not just a thing that we see with COVID vaccine, it's a thing that we see with all vaccines. And we know that there are certain groups who are less confident around vaccination in general. So just kind of going above and beyond to make sure that we do our best to explain things and use the science, as Eleanor was saying, is really important. And I think as well, we looked at, just briefly on the first slide, there were the groups of people that were prioritised according to their underlying medical problems and according to their age. But we also know that with COVID in particular, there are high-risk groups that aren't necessarily captured by those criteria. So there are high-risk groups if you happen to be from certain ethnic backgrounds. We know that people from Black and Asian minority ethnic backgrounds were both at higher risk of serious illness from COVID and at higher risk of death. And also people who were living in poverty and in more deprived areas, again, much higher risk of serious illness and death. So these groups are often also harder to reach. And I know that a lot of the discussion tonight will probably focus around that. So they are high risk and harder to reach. And so we probably have to go above and beyond to make sure that they have the very best chance of being vaccinated. But all in all, I think, as Eleanor was saying, it is a huge success story, given the scale of the rollout of a new vaccine. Where we think about where we were a year ago, we've managed to vaccinate more than 90% of everyone over 60, around 85% of the 50 to 59, and around 30% of those over the age of 16. So it's going pretty well, all in all. And just briefly thinking about who are the harder to reach groups. We know, again, from looking at vaccination over the years, particularly looking at data from flu vaccine, that people in certain communities are more likely to have lower levels of vaccine uptake. So if you're homeless or rough sleeping, if you're in the gypsy or traveller community, if you're living in poverty, if you've got significant mental health issues, substance misuse issues, or you're from certain ethnic minority groups, you are less likely to want to take the vaccine or have easy access to the vaccine. So there is work to do to make sure that some of these harder to reach groups who are also high risk get the very best opportunities to be vaccinated. And the latest vaccine figures from Public Health Scotland would tend to show that this is what we are seeing. We're seeing that vaccine uptake is higher in the more affluent areas and higher in white groups as well. So just some useful resources which I thought might be useful to share. You probably have these, but the National Vaccine Line, this is how people have to reschedule their appointments if they're being done out with their surgery. And there's also a general information line is there. There's a huge amount of information on the COVID-19 vaccine on the NHS Inform website, and we use that quite a lot when we're speaking to patients about the vaccine and potential side effects. There's just loads of links there. We can often text them to patients as well, just to read. Lothian unpaid carers can now self-register on a page on the Lothian intranet, which I've included there as well. And for people who are struggling with transport, which is a reasonable amount of people actually, there is an email that they can use, which is COVID_19. It gets a little bit lost with that line there. responsescotland@redcross.org.uk. Now this has just been recently launched, so the Red Cross are kind of coordinating a national effort to try and help people with transport difficulties so that they can get to their vaccination. So they've said that they're happy to receive queries coming in on that email, so I thought that might be useful to share as well. So I shall stop sharing now. Thank you very much.
Carey, thank you, and Eleanor, thank you so much. That's so informative. So I've got a couple of written questions here for you both, one each, and then I'll pass over to my colleague Kate, who will watch the room for people who want to ask further follow-up questions. So first of all, I'll read them both out. Carey, can you give us an example of actions that have been taken to improve confidence for a hesitant community? And Eleanor, many people now have had their first dose, and some have had a reaction that's pretty bad. What's the evidence about the second dose? What do you know? Okay, so there's two questions, and handing over to Kate as well. Thanks, guys.
Thanks, Ian. Thinking, I guess, about there's quite a lot of good examples actually about how we can engage well with hesitant communities. So, for example, if we take the homeless or rough sleeping community, then there's nothing that beats a proactive outreach approach into those communities in locations where people feel comfortable and often offer other stuff too. So there's some great examples of being able to get really good vaccination uptake rates in places where, for example, there has also been STI screening, BBV screening, vaccination, general health advice, and a free vet to be able to see the dogs as well. So just some innovative approaches around what are the things that really matter to people who are homeless and rough sleeping. Let's bring them all together and do it at a time in a drop-in fashion where uptake rates are often high. And I think nothing substitutes having people who are respected and known by local communities talking confidently about vaccination. So again, just thinking about some of the minority ethnic groups, when the vaccination has happened in mosques or faith leaders have felt confident in being able to discuss vaccination, we see vaccination rates going up. So I think that there's something just so important about being able to speak to a trusted source and not feeling embarrassed to do that. Someone who knows what the specific challenges will be. Lots of other examples too, but they're two. Thanks.
Yeah, and just to add to that, if you or your colleagues are going to be involved in doing this, really please make sure you get your vaccine as soon as you are able, because it's very difficult to convince somebody else to do something if they ask you, have you had it? And the answer is no. Okay, so your role as role models is also really important. I'm sure I didn't need to say that. And I am actually just going to share something else with you before I answer the question. I was made aware just last week of a website which has been not well advertised at all. that if you've already had your letter and been given a username, you can go onto this website and you can online change your appointments, your first appointment or your second appointment, but you do need to have that username, which comes on the letter that you get in the blue envelope. And it's really important, if you can say to people, if you keep your first letter with that username, you can then go on and book your second appointment. And for people who are competent and confident to use the internet to do this, but who struggle with other forms of engagement, this is a really important. When I've finished nattering, I'll type the website into the chat, but basically it's vacs.nhs.scot/CSP, whatever that stands for, but I'll type it into the chat in a minute. And I used it and was able to change my appointment to a time that suited me, so that was good. So how do you react to the first dose and the second dose? So it depends which vaccine you've had. So the fairly strong evidence for the AstraZeneca vaccine is that if you had a bad reaction the first time around, the second time around it's much less severe and really quite mild. It's not non-existent, and people who've had their second dose can feel a bit fluey, a bit tired for a couple of days, but I know of people who've been essentially sent to bed for a week by their first AstraZeneca vaccine. The second one does not on the whole do that to you. The story for the Pfizer vaccine is slightly the other way around. There are quite a few people who've had a very mild response to the first one and got hit a little bit harder the second time around. But the Pfizer one doesn't seem to give you those I need to go to a bed for a week type side effects. So on balance, not so bad the second time around.